Welcome to this explainer. Today, we are tearing into the brand new 2025 Acute Coronary Syndrome guidelines. We're going straight into the high-stakes, adrenaline-fueled world of the emergency department. We're going to break down the exact protocols, the ticking clock, and the massive updates that are fundamentally changing how medical teams save lives during a cardiac event. So, whether you're a healthcare pro or you just want to understand the modern reality of surviving a heart attack, you are in the right place.
Okay, let's dive right into this. Time is muscle. It's a phrase you'll hear echoing down the halls of literally any cardiology unit, and it's the absolute core of our explainer today. In a heart attack, every single second that passes without blood flow directly correlates to permanent, irreversible heart muscle loss. The clock starts the exact second a patient feels that chest pain. Everything we're about to cover is designed to beat that clock, because the stakes, they honestly could not be higher.
Section 1, Anatomy of the Crisis. To really get why speed is so absolutely critical, we've got to look under the hood at the hidden physical mechanics of a cardiac event. So, acute coronary syndrome, or ACS, isn't just one single disease. It's a whole spectrum of conditions where the heart muscle is either starved of oxygen, which we call ischemia, or it's actively dying, which is infarction. Now, this spectrum includes unstable angina, NSTEMI, and STEMI. But here's a really fascinating takeaway from the latest data. Unstable angina is actually becoming pretty uncommon. You might be wondering, why is that? Well, it's because our modern high-sensitivity troponin blood tests are just incredibly good at detecting even microscopic amounts of heart damage. Cases that doctors used to vaguely label as unstable angina are now accurately diagnosed right out of the gate as actual infarctions. So what's actually happening inside the body during those first terrifying moments? It almost always starts with a silent killer. An atherosclerotic plaque inside a coronary artery ruptures, erodes, or fissures. And your body reacts to this rupture just like it would to a sudden cut on your finger, right? Platelets rush in to fix the damage. They clump together, and they form a thrombus, which is just a blood clot. In a matter of seconds, this clot causes a partial or complete occlusion of the coronary artery. The oxygen supply is abruptly cut off, leading to severe ischemia. And if that vessel isn't open fast, you cross the point of no return into irreversible infarction. Moving on to Section 2, the 10-minute ED race. That rapid biological chain reaction brings our patient straight through the emergency department doors, triggering what medical teams know as the critical first window of action. The second a patient with suspected ACS comes through those doors, the ED staff has exactly 10 minutes. 10 minutes! The evaluation has to be lightning fast because the therapies we have only work if they're applied immediately. Within this incredibly strict 10-minute window, 3 specific things have to happen all at once. First, a 12-lead ECG is ordered stat. Second, they do a focused history and physical exam to check the patient's baseline neurological status and bleeding risks. And third, blood is drawn for high-sensitivity troponin and other labs. The one singular goal of these chaotic 10 minutes? Instantly identifying a life-threatening STEMI. But, and this is a massive warning for anyone analyzing these initial tests, a single, normal troponin result that absolutely does not rule out ACS. Because it takes time for the dying heart muscle to break apart and release those proteins into the bloodstream. That very first blood draw in the ED might look completely fine. Getting a false sense of security here can be deadly. Serial measurements are absolutely essential. The guidelines specifically require repeating that test 1 to 3 hours later, looking for a dynamic rise or fall above the 99th percentile to definitively confirm what's going on. Which brings us to Section 3, stopping the clock. Once the assessment is underway, the medical team is simultaneously jumping in to halt the damage. Now, what's really interesting here is how the 2025 guidelines have totally flipped the classic MONA protocol on its head. For decades, giving morphine, oxygen, nitroglycerin, and aspirin to chest pain patients was practically just an automatic reflex in hospitals. But not anymore. Check out these drastic updates. Morphine, it's no longer routine. It is reserved strictly for severe, persistent pain that nothing else can touch. Oxygen is heavily restricted now too. You only get it if you're actually hypoxemic, meaning your oxygen saturation has dropped below 90%. Nitroglycerin is still used for persistent discomfort, but aspirin remains the undisputed, unchanged champion. 162 to 325 milligrams, chewed and swallowed immediately, is absolutely still your very first line of defense. But listen, chewed aspirin alone isn't going to fix this crisis. The absolute cornerstones of stopping that clot from growing are dual antiplatelet therapy, or DAPT, and anticoagulation.
The 2025 update makes a really clear preference here. The drugs ticagrelor or prasugrel are now preferred over the older standby clopidogrel for all ACS patients. You combine that with a systemic anticoagulant like heparin to completely freeze the clot in its tracks. And crucially, this is not a one-size-fits-all situation. Dosing has to be very carefully calculated based on the patient's specific weight and kidney function to avoid catastrophic bleeding.
Section 4. STEMI versus NSTEMI, branching paths. At this exact point in the timeline, the ED team gets the results of that 10-minute ECG, and it forces a choice between vastly different life or death decisions.
And this brilliantly illustrates those two distinct clinical paths. With a STEMI, or ST elevation myocardial infarction, the physician is urgently looking for a new ST elevation at the J point in two contiguous leads, or a new left bundle branch block. If they see this, it means a major coronary artery is 100% blocked, period. With an NSTEMI, it shows up differently. You aren't going to see that massive elevation. Instead, you'll spot a horizontal or downsloping ST depression, or a T-wave inversion. Make no mistake, both of these are extremely dangerous heart attacks, but how they are managed over the next few hours is completely different.
If that ECG shows a STEMI, the hospital goes into absolute hyperdrive. From the exact moment the patient crosses the ED threshold, the target to get them physically into the catheterization lab and inflate a balloon inside their blocked artery, which we call primary PCI, is less than 90 minutes. Door to balloon. Less than 90 minutes. If it's a smaller facility without a cath lab and PCI just can't be done within 120 minutes, they don't sit around waiting. They immediately pivot to fibrinolytic therapy, which are these powerful systemic clot-busting drugs just to force that artery open. Now, if the ECG shows an NSTEMI, the game changes. Reperfusion isn't instantly emergent unless the patient is hemodynamically unstable. The clock is definitely still ticking, but the medical team gets a tiny bit of breathing room. They use this window to deploy risk stratification tools, like the GRACE score to predict mortality, or the HEART score to predict adverse events. Based on those numbers, high-risk NSTEMI patients will get an early invasive strategy within 24 hours, while lower-risk patients might just be managed medically and evaluated with stress testing. Section 5. Complications and special populations. Because look, medical protocols are great, but patients don't exist in a vacuum, right? We have to tackle the unique challenges that can derail even the most perfect clinical timeline. You really have to stay on your toes here, because a real-life heart attack rarely looks like some dramatic movie scene with a guy clutching his chest. This is incredibly important to remember. Women and the elderly frequently present with highly atypical symptoms, things like unexplained fatigue, sudden nausea, or back pain. Diabetics face the terrifying risk of a silent ischemia, where nerve damage basically masks the pain entirely. And hey, even if the blockage is successfully cleared, the danger is far from over. In the first 24 hours, deadly chaotic heart rhythms, arrhythmias like ventricular tachycardia and fibrillation, are the absolute top cause of death. Plus, if the heart muscle is severely damaged, it can trigger cardiogenic shock, which remains the single most common cause of in-hospital death for these patients. Finally, Section 6, the 2025 Discharge Guidelines. So let's say the patient survives the initial crisis, the procedure, and the complications. Huge win. But the journey definitely doesn't end there. So the crucial point here is that number 55, less than 55 milligrams per deciliter, that is the super aggressive new 2025 target for LDL cholesterol. The latest guidelines now mandate that all ACS patients be started on a high-potency statin immediately. Doctors don't wait for discharge anymore. They start it right there in the ED or during the initial hospital stay. If a patient is already taking a statin and they still aren't hitting this ultra-low target of 55, physicians are instructed to immediately throw in non-statin therapies like ezetimibe or PCSK9 inhibitors, just to force that cholesterol down. To actually hit those aggressive targets, the 2025 updates heavily emphasize a mandatory checklist-based approach before a patient even thinks about leaving the hospital. These aren't just suggestions, they are standard operating procedure. We are talking strict medication reconciliation to guarantee the patient is on their dual antiplatelets, statins, ACE inhibitors, and beta blockers. A referral to cardiac rehab is strongly recommended for everyone. Lifestyle modification counseling is locked in. And crucially, a physical follow-up appointment must be scheduled within 7 days, paired with intense patient education on how to recognize if their dangerous symptoms are coming back. We've just seen how a structured, protocol-driven approach in those first 10 minutes literally saves lives. But as we look at these strict new discharge rules, it leaves us with a massive question to consider. With checklists and protocols clearly saving lives after the fact, Are we, as a medical community and as patients, ready to treat lifelong secondary prevention with the exact same intense urgency as we do those first 10 minutes in the ER? Because ultimately, preventing the next clock from ever starting is the greatest victory of all. Thank you so much for joining me on this explainer, and keep learning.
Thank you for watching this edition of the Emergency Medicine series. If you found this session valuable, please click the subscribe button below and turn on notifications to never miss an episode. Stay safe, keep learning, and I'll see you in the next lecture.